We're gonna do Debbie's. We're gonna do Debbie's.
Hi, everyone. Yes, we're going to start now with dental. And let me pull that up, and oral care, and let me pull that up for Elizabeth. Oops, hold on. Technical difficulties, not difficulties, but share. And
I like it.
we should be good to go.
All righty. Hi, guys. Again. Oh, I did that again. I want. Yeah, I just like to move this thing up in the corner so I can see everything. All righty. So we're going to start with dental and oral disorders. There's a whole lot going on in the mouth that causes a lot of issues. Now, this is short and sweet and to the point. One of the things that you will see on one of your extra papers is this this outline of the teeth and the mouth, so that you can be very specific in your charting if you want to. So the A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P, Q, R, S, T are your primary teeth. Okay, so this page has a top and a bottom, and it's divided the mouth by cross section and quadrants. So when you're looking at, let's say they get their first two bottom teeth, that's going to be P and O. And then if they get their top two teeth, that's E and F. And you can document that specifically because this is a standardized, this was given to me by a dentist. And she said, this will help you in your practice. So, and you will see that I have written on the sides that number 4 and number 5 will replace your A and B. So as premolars come out with their baby teeth, they're replaced by others. And you'll see in each quadrant where certain baby teeth are replaced by other teeth and what their numbers are. So this is a great reference tool. I keep it at work where I can get to it, especially when I'm charting. So with that said, we're going to move on with this. So, all right, so tooth eruption usually occurs in a very predictable pattern. Not always, because I have had some that get certain teeth before they get others, but usually it starts between 6 and 8 months of age. Not always, but that is your rule of thumb. And you usually start with the 2 bottom teeth. It goes 2, 2, 2, 2. So you get these 8 front first. Sometimes others will come in. And we use that rule of 6. We take their age in months minus 6, and that's about the number of teeth that they have. Now, there are 20 primary teeth, and they usually have those somewhere between 2, 2.5 have all come in. Sometimes before, sometimes it's later, depending on, certain things. Sometimes prematurity status can cause a delay in dentation or dentation because of just from being a preemie. But if you don't have any, and sometimes it doesn't happen until after their first year. But if you're concerned, if there's no teeth popping through, sometimes an x-ray or sending them to the peds dentist for further evaluation, especially if they've got no teeth by the time they're 15 to 18 months old. You might want to go ahead and send them to the dentist and have that further evaluated. All of their primary teeth and their adult teeth are formed in their gums when they're born. So if you do happen to do a head x-ray of a small child, you see all those teeth up in the gums, and it's just amazing. So they're all there if they're going to be. So now, some of the things that it's okay. It didn't tab over, but that's okay. So we're going to talk about preventing dental issues. It didn't do when I did that. Nope. Yeah, I'm just going. That's all good. That's where I'm at. I'm already there.
I'm being nosy. Sorry.
That's all right. That's all right. She's trying to help me. Fluoride supplementation usually starts at 6 months old if your water supply is deficient. We used to give, back in the day when my children were little, if you were a breastfeeding mom, you used to get a multivitamin with fluoride in it to supply. Now, fluoride varnish is also one of the big things that we were doing back when I was as a student in UK back in 2004 and 5. We were applying fluoride varnish at well child visits to all primary teeth. My dentist now does a fluoride varnish, or my hygienist does at the end, and I'm like going, I'm going to drink coffee as soon as I get out of here. And she looks at me and I said, just give it to me and I'll put it on when I get home. But most of the time I don't, so we won't go there. But anyway, fluoride varnish now is a big deal. Of course, our water supply is fluoridated if you have what we call city water. Now, when I was a little girl, most people didn't have city water. I remember when it came through, because we had a cistern. A lot of people had wells. In Eastern Kentucky, it was very common that everybody had you had well water, and those weren't fluoridated. So fluoride supplementation was important, but it's really important not to over fluoridate. So so we can do fluoride varnish in the primary care or the PCP's office, as well as the dentist does it. We can also get paid for oral assessments and fluoride varnish. One of the things that I have to do now when I am charting, we talked about this at the very first of the semester about requirements with Medicare, Medicaid, or Medicaid from my perspective, is that I have to document that they drink city water that's fluoridated and that they use a fluoridated toothpaste, and whether or not they have seen the dentist yet. So that starts at about 15 months of age, where I have to put that in either my HPI or somewhere in the note. Okay. So if you want it, I've done fluoride varnish. It is not easy and it takes a lot of time. So if you're cramped for time, it's not one of the things that I would encourage. It, like I said, it's a good reimbursement. If you've got time to do it, that's great. If you don't, then let the dentist do it. But make sure that they're getting some kind of fluoride in their diet. Over fluoridization can cause fluorosis, that shiny white spots on the teeth, and can also cause a softening of the teeth and a yellowing of the teeth. So there's this unique balance between enough and not enough. So, and you have to be careful with bottled water, because not all bottled water is fluoridated. So if you are drinking bottled water because your tap water is pitiful, or you just choose to do that because you think that's better, then you need to make sure that you're getting sources of fluoride otherwise. Okay, so that's something to talk to your patients about and parents. Dental caries. This is a significant issue in pediatrics because this can cause other health issues. When we're not COVID-19 quarantine, I do at least 1 to 2 dental pre-op exams a week for dental surgery, so they can do work under anesthesia, which means that their caries, they've got enough significant caries that they want to do it under anesthesia, so they don't traumatize the child. So it seems anymore they want to put them to sleep so they don't remember that they've had anything done. And they have to do that in the auspices of a OR type situation in case there's complications. So I've seen huge issues with baby bottle tooth decay, and that's usually the culprit, where that's one of the reasons we start pushing cup instead of bottle starting at 6 months of age. But babies, especially nighttime feedings, because a lot of times if they should be sleeping through the night and if they're bigger babies and they're getting up and taking a bottle 2 or 3 times a night, that milk sugar is just sitting on their teeth. And this even includes breast milk. Or they suck on a bottle all the time. Just kills me with toddlers running around with a bottle in their hand. and just have it in their mouth, and they're taking juice and juice and juice and milk, and it just sits there. So cleaning teeth, cleaning oral starts very early, or it should. But I've seen rotten teeth and it's right at the gum line, and some severe cavities. And like I said, this can cause other health issues in kids. All right, we should be actively looking at teeth with each exam. You just don't look at the back of the throat. You need to be looking at the teeth. So you're pushing out, you're using your tongue blade and you're pushing out the buccal mucosa. So once you've looked in the back of your mouth, they'll say, now I want to look at your teeth. So they'll go like this. And it's like, no, I need to look at all your teeth. So open your mouth a little bit wide. I promise not to gag you. Or if you may even want to do that first before you look in the back of their throat. And you use that tongue blade to push those cheeks out, and you look down and you look up, and you're looking for cavities or any swelling or redness in the gum. This especially is really important at a well child exam. So you're asking those questions about, are they brushing their teeth? Are they going to the dentist? We really start pushing that at 18 months of age. However, several of your dentists don't want to see them before they're 2 or 3. So if you have, here in town, we've got 3 pediatric sets of dentist offices. Some people like their own private dentist that the whole family goes to, and if they've contacted their dentist and says, oh, they don't want to see them until they're blah, blah, blah. I document that, discussed seeing the dentist, mom has contacted a personal dentist and doesn't want to see child until a certain age. I've assessed and I have done what I was supposed to do, and I documented that, okay? The American Academy of Pediatric Dentistry recommends dentists by 12 months of age or with first tooth eruption. That's usually still pretty early, but you want at least a soft cloth or one of those little finger caught rubby things that you can rub those teeth to get the milk sugars off. And like I said, in my slide, it says reality is that most of the time the dentists don't want to see them until most of their primary teeth are in, and that's somewhere between 18 months and 2 years of age. I talked about this, start the conversation at a well child exam as soon as those teeth come out. You're not using toothpaste yet, but you're actively wiping. Sometimes there is that what they call trainer toothpaste. You don't want anything with fluoride in it at this point because they're going to swallow more than anything. They're not able to, brush and spit out. With your toddlers, you're trying to teach some independence. So you want them to brush, but you're going to have to follow up behind them and make sure it's done right. So we're going to look at some oral conditions. This is stomatitis, oral lesions. So there's not a whole lot. There's not an antibiotic that's going to make this go away. If you've ever had an aphthous ulcer or stomatitis, you know how painful it can be, especially in kids, smaller kids. They don't want to eat. They don't want to drink because it hurts. There's not a whole lot we can do about that. You want to give them something for pain. Sometimes we'll use some magic mouthwash. If they can swish and spit, that's one thing. If they can't, it's totally different. So if they can't swish and spit, we're going to give them a mixture of Benadryl, Maalox, and maybe even some oral nystatin. But you want to make sure to tell the parent not to give them a drink of something else afterward, because the Maalox helps coat. It's also got zinc oxide in it, and the Benadryl helps as an antihistamine effect. If you give them a drink right after it, then you just washed it all away. And then nystatin, of course, is an antifungal in case there's that component in there. Now, if they're able to swish and spit, we might also add some viscous lidocaine in there, so to help with the pain. But if they can't swish and spit, I'm not going to put xylocaine in that, because if they swallow it, then that can, the reason we don't use baby oral gel anymore for teething is because it can numb the gag reflex, and they can choke and aspirate and not even know it. So like I said, I don't use the viscous xylocaine much anymore. They have to be pretty big to be able to swish and spit for me to feel comfortable doing it, like my adolescents, older school age kids. Well, I said stomatitis, aphthous ulcers. You see how they've got the white halo, they're white with a gray or yellow center. and it can be one lesion or multiple. And see, that's what you've got with your stomatitis, just more of it. And see how red the gums are with the stomatitis. Your aphthous ulcers, like I said, can be either on the lip, in the buccal mucosa, or at the gum line. Again, we want to heal the pain, reduce the pain, and heal the ulcer, and you're going to use the same things that we talked about for stomatitis. Benign migratory glossitis, otherwise known as geographic tongue. Geographic tongue can be normal, or it can be a sign of another condition, but if their tongue looks like this all the time, then they just have geographic tongue, and they think they've got sores. As long as their tongue is not sore and they're eating and drinking okay, it doesn't seem to be bothering. This is geographic tongue, and there's not a whole lot you can do about it. It just is what it is. But sometimes just reassurance that this is normal and this is what it's called makes a parent feel better. Now, this is really interesting. This is a mucocele, and these are salivary gland lesions, and it causes a blockage of the duct. It's very common on the lower lip, and it's a fluid-filled vesicle or a movable nodule. And I have seen one of these. Most of the time, you have to send them to the dentist or oral surgeon for them to take care of this, to excise it. That was a huge learning. I had no idea. I went and got like, that doesn't look like an aphthous ulcer. That looks like something else. That's huge. It was huge. The one I had on the patient was huge, probably about the size of a big piece of hominy, but it wasn't white. It just was fluid filled like that. And the doc that I was working for, daughter, was a dentist. So he contacted her after he saw me, and he says, got this patient, blah, 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 blah. She said, oh, that's a mucocele, blah, 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 blah. And he said, yeah, that's what, I knew that. So it was a teaching time for me. So I learned a lot about that. So be on the lookout for things like that. But no antibiotics or anything is going to take care of it. Those have to go to the dentist or oral surgeon. So, yeah. Cleft lip and palate issues, the hard palate in the top of the mouth and the frontal area, lip, palate, nose, it all works together. If there's going to be an issue, it usually occurs during interuterine development, and it's a failure of the shells to fuse. A lot of genetic factors can affect the cleft lip more than the palate. Combination of both is most common, and it is more common in males than females. It involves not only the soft palate, the hard palate, and then again, the nasal passages, because that's just right above it, and then the lip. What's really interesting, if you've got kids with a bifurcated uvula, okay, you know what I'm talking about, the uvula, if it looks like, this is going to sound awful, it almost looks like a little scrotum hanging down when it's bifurcated. You're laughing at me, Dr. Blankenship.
No, ma'am.
But have you ever seen it? Bifurcated uvula? Once. Is that not what it looks like?
Exactly.
Okay. You should suspect that even though the skin over the hard palate is connected and in place, there may be the hard palate may actually be open. The bone may not have fused underneath. So you need to be feeling the upper, the roof of the mouth. Even though the skin is across it, that's usually a good thing. And I've had a couple of those where they've had a bifurcated uvula. I felt they had an opening. You could feel the ridge open between the palate structures, but the skin was intact. And I went to my doc and said, I think I've got a submucosal cleft palate. Well, is the skin, yes, they weren't having any problems with breathing. Sometimes it can affect speech, so you have to be really careful with that and be cognizant of that. But they're not having any feeding issues, eating issues, breathing issues, and it's not an open, there's nothing open per se. So what are you going to do? What are you going to do about it? You're going to watch it and just make sure that the parents are aware. And like I said, sometimes it can cause some speech issues because the tongue may not hit exactly right. Oh, I keep hitting the, okay. Yeah, no interventions usually required. Monitor for speech. Clefts are not immediately repaired. That's the interesting part. If they're born with a cleft lip and cleft palate, feeding becomes a challenge. And so they have special nipples and special things that they use for feeding to bypass that opening to get it to where that they can get, so they're not choking, okay, on their feet. Unless it just gets to the point that they're having so much trouble feeding that they go ahead and do something. And sometimes it's a temporary, and sometimes these have to be done in stages as the child grows. And dental restoration is usually frequently required in these kids. So some of them are very minor that you can't hardly tell that they've had anything, and some of them were very extensive. But usually, like I said, there's usually a speech issue with this, even if it's minor. And these kids are going to be in speech therapy. But significant support of the frustrated parent. They're worried about their child. This is not the beautiful baby that they were supposed to have. They've got this opening in their lip. Feeding is a chore. They choke frequently. They're scared to death. And they're not going to fix it for a while. So these parents need a lot of reassurance. They may make frequent visits to your office just out of panic and concern. Do not get exasperated with them. They just need a lot of TLC and reassurance. But then also be on the lookout for significant issues, because if they've aspirated, you can always have aspiration pneumonia. So these kids have a tendency to aspirate more. So just more stuff to look out for. So here are some different, there's your bifurcated, that is a mildly bifurcated uvula. The one on your right is a significant bifurcated uvula. And then this is this sweet little kid with a significant cleft lip and palate prior to surgery, and there he is after surgery. And if you couldn't see the scar, you might, and you can see a little bit as far as malformed nose on the left-hand side of the nary area, but otherwise, isn't he sweet? Isn't he cute? So significant, just sweet babies. Okay, so here are some structural how these come along. So you've got a nose and palate involved at upper, then you've got let's see, B is both nares are involved. C is one nary and significant opening to all the way back. And then D is got both nares and both passageways. And E, the nose is not involved and it's just the palate opening. And you don't see that as often, but it is potential. So those are some of the things you're going to see, and dental and orals are short and sweet and to the point. So again, if you've got questions, contact us, contact Dr. Blankenship. I'll be glad to get any answers. So I will get off and let her stop this.